welcome to the Premi Chat. Thank you so much for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation. CPBF is a charitable organization, and our mission is to empower families of premature babies through support and education. This Premi Chat series is one of the many initiatives we have to bring information for NICU families and healthcare professionals. Here, every Friday, we talk with experts, researchers, and parents who share with us their experience and knowledge. Also on our website, canadianpremis.org, parents will find all kinds of resources and support. One of them is the Parent Care Program. We are offering 4 free therapy sessions for families who are currently in the NICU or those who have been discharged up to 3 years. All the information is also on our website. And today we are going to talk about cell therapy for complications of extreme prematurity. Despite progress in perinatal care, complications of extreme preterm birth remain a major public health issue. There is a lack of specific therapies that target injury prevention and organ development and maturation. Cell-based therapies offer a new hope in preventing and/or restoring organ damage in extreme preterm infants. This presentation will summarize the long journey from discovery to early phase clinical trials. While the excitement is palpable, a cautious, evidence-based approach is critical to establish whether this novel disruptive approach can fulfill its promise in substantially improving the health of extreme preterm infants. And I have here join me live from Ottawa, Dr. Bernard Thibault, who is a clinician scientist with a focus on the clinical translation of stem cell-based and gene therapies for lung diseases. He's a senior scientist with the Ottawa Hospital Research Institute and a neonatologist with the Children's Hospital of Eastern Ontario, providing care to critically ill newborns. He's also professor of pediatrics at the University of Ottawa. Dr. Thibault studies the mechanism of lung development, injury, and repair to design new treatments for incurable lung diseases. Over the next 5 years, his goal is to bring safe and effective cell and gene therapies for lung diseases into the clinic to improve patient outcomes. Dr. Thibault, thank you so much for joining us here today. I am super excited about this talk. Every time we talk about how science is moving forward and what we're studying, I get really excited because this is so much hope for the future. So thank you for joining us today.
Thank you very much, Fabiana, for inviting me. I'm also very excited to be here and to share with you our journey to bring cell therapies from the laboratory bench into where it actually matters, and it's our patients. And so this presentation will very quickly summarize the last 15 years or so where we discovered the potential for stem cells or repair cells to protect the developing lung. First in exploratory studies in the Petri dish, and then in small laboratory models to large animal models, which is very important to obtain regulatory approval from Health Canada, for example, to move into clinical trials. And this is the classical path from discovery to clinical translation, and whereas here it can be summarized in one slide, it usually takes 10 to 20 years and over $1 billion to achieve, and it actually often fails, and I will show you how we try to mitigate the risk in order to enhance the success of clinical translation. And the focus of our lab is clearly the translation. If we do not see a clear path within 5 to 10 years for a discovery to get into the clinic, we do not focus on it. It will not mean that in a few years from now, when this discovery appears more interesting, that we're not coming back to it. But the return on investment has to be within 5 to 10 years because patients are waiting, and they deserve our full attention and the focus on getting things from the lab into the clinic. And so we all agree that preterm birth complications is a major problem because actually of our success in pushing back the limits of viability. Complications of preterm birth are now the main cause of death in children below the age of 5 years. And you recognize the different complications for which we currently don't have any specific treatment, whether it's necrotizing enterocolitis, periventricular leukomalacia, or intraventricular hemorrhage. Severe sepsis, yes, we have antibiotics, but if there's severe inflammation, we sometimes have trouble. And the main chronic lung disease of prematurity or bronchopulmonary dysplasia is one of our focus in the lab because it is the most frequent and most severe problem. And so the challenge that we have is that the organs that we're trying to protect are still developing, since babies are born too early. And the focus again on of our lab is on the lung, but what I will be presenting about the lung also holds true for the brain, the kidney, or the heart, for example. And one of the biggest issues in neonatology is to prevent lung injury. These small little bubbles at the distal part of our lungs are the alveoli, where gas exchange happens. And these respiratory or breathing units have not yet fully developed in preterm babies, explaining the respiratory distress. But during the course of their journey in the intensive care unit, the development of these respiratory units is halted, resulting in an arrest of alveolar development, leading to something that looks in the end like a smoker lung. And so the challenge of preventing this bronchopulmonary dysplasia is highlighted here. And so this slide shows the different stages of lung development as they occur through the embryonic, pseudoglandular, canalicular stage, and alveolar stage. And so this is all happening in utero. And it's only at birth that the lung becomes really completely functional with the development of these respiratory units. And when BPD was described for the first time in 1967, babies were born around 34 weeks, and these were the ones at risk of developing BPD. You can see that their lungs are at the late sacral stage, so already fairly developed. And what progress in neonatology and perinatology has allowed is to push back the limits of viability with the discovery of surfactant, antenatal steroids, and other incremental improvements. We have pushed back the limits of viability to babies now born at 22, 23, 24 weeks gestation, and these are the ones that are now at risk of developing BPD. But you can see now the increased challenge, because these babies now are born at an earlier stage of lung development, the canalicular stage, just when the airways get close to the blood vessel and gas exchange is actually feasible. And in addition to being born preterm, Other events happen before birth, preeclampsia causing growth restriction, chorioamnionitis causing inflammation, and all these events impact already the developing lung and may set it up for later BPD. At birth, the same strategies that keep the babies alive may also cause some lung damage, such as the mechanical ventilation and the oxygen therapy. And then, should an infection occur or enterocolitis, then these events further impede normal lung growth. And postnatal glucocorticoids, I'm sure you have heard of the DART protocol, also further impede normal lung but also brain growth while attenuating inflammation. So it's always a double-edged sword when we try to prescribe postnatal glucocorticoids to improve the outcome of our babies. So clearly what you can see is that BPD is a multifactorial disease characterized by an arrest in alveolar or in lung development. And so what we're trying to do is to prevent the injury while at the same time promoting lung growth. And there is no such medication that allows this so far. Postnatal steroids allow to dampen the inflammation, but impede lung growth. So clearly, we need something. We need a new breakthrough. And our lab has embraced the potential of stem cells in organ regeneration. The discovery of stem cells is Canadian and dates back to 1961. And Till and McCulloch established the principle of self-renewal, meaning that the cell can replicate itself forever, and differentiation. Under certain circumstances, this cell can become any type of cell, and this is called a pluripotent stem cell. And it is these properties that we thought to harness to repair the damaged lung. And so around the 1970s, another researcher, Friedenstein, discovered that next to these hematopoietic stem cells that Till and McCulloch described, there was a niche cell important to make sure that these hematopoietic stem cells work well. But these niche cells, later called mesenchymal stromal cells or MSCs, had also some self-renewal and differentiation potential because they could become cartilage, fat, or bone. But when around the turn of the century in 2000, a researcher showed that in mice with myocardial infarct, these mesenchymal stromal cells could promote heart repair, there was a dramatic exponential interest in these mesenchymal stromal cells for organ repair. And we have also tried to take advantage of these mesenchymal stromal cells. The definition of these cells is still a matter of controversy, and this is well described in this editorial here. But the studies in the laboratory were so promising that many investigators looked at the potential repair properties of mesenchymal stromal cells, including our lab. And so here the idea was that if we would inject these cells, they would be able to home to the injured lung and replace the lung cells that have been damaged, and then repair and restore normal lung homeostasis. However, what our research found is that instead of replacing the dead cells, these mesenchymal stromal cells would indeed migrate to the lung, but they would not stay there. Rather, they would orchestrate and coordinate the repair process by producing communication factors and biological factors that would promote lung repair and eventually lung growth. And specifically focused on bronchopulmonary dysplasia, where we have this pleiotropic effects or pleiotropic multifactorial disease, mesenchymal stromal cells may actually represent this perfect therapy that we're looking for, the one that attenuates inflammation, reduces the toxicity of oxygen, and at the same time promotes lung growth. And in addition, what we found out over time is that these mesenchymal stromal cells, they can actually be retrieved elsewhere than from the bone marrow, actually from the umbilical cord. And for us neonatologists, this was the perfect clinically relevant source of mesenchymal stromal cells, because you can obtain it after birth without any risk to the mother or the baby, and you can then extract from this tissue these mesenchymal stromal cells in much higher numbers than what one could get from the bone marrow. What is also exciting and still in the making is that these mesenchymal stromal cells from the cord may actually have superior repair potential than the so far exclusively used bone marrow-derived MSCs. And you can see now in clinical trials, the cord tissue as a source becoming the primary source as opposed to bone marrow. Here is a typical experiment that we would perform in the laboratory, where we take the human umbilical cord, digest it, and extract the cells, plate them, expand them, and then we would perform our experiments by injecting these cells into our animal model of bronchopulmonary dysplasia, and we would then look at the lungs to see if we could protect or prevent the injury. Here, this is a normal lung when it's sliced and looked under a microscope, and you can see tiny little bubbles that are the alveoli, those gas exchanging units. Here you can see them under a fancy scanning electron microscope. And here you can see the dense vascular network that is so important to carry the oxygen. And here, conversely, you have our BPD model where you can see the arrest in alveolar development with large and non-efficient gas exchanging units. And as well, there's very few blood vessels in the lung, further compromising gas exchange. When we give these mesenchymal stromal cells, and this was work done by Maria Piero, who's now back in Italy, a neonatologist that worked diligently on these experiments, and we keep collaborating together. You can see here the dramatic arrest in alveolar development in our BPD model. And when we give mesenchymal stromal cells, you can see that this lung looks much more than a control healthy lung. And so we're very excited about these results with cord-derived mesenchymal stromal cells. Then when we looked 6 months later for long-term efficacy and safety, 6 months in these laboratory animals is the equivalent of 20 to 30 years in human lives. We could not see any tumor formation in these animals. Exercise capacity, when we run them on a treadmill, was dramatically reduced in those mice or rats that were exposed to oxygen in the neonatal period. And you can see that those animals that received MSCs had preserved exercise capacity. Likewise, 6 months later, you can see these animals that they have still the arrest in alveolar development, whereas MSC-treated animals had normal looking lung architecture. Likewise, when we injected healthy animals with the cells, we did not see any disruption of lung architecture, again suggesting that in this model, this cell therapy is safe. So because of the pleiotropic effects, and because we were worried that attenuating inflammation with these mesenchymal stromal cells could cause problems in babies that have sepsis, for example, similar to what happens when we provide steroids, we developed an animal model of sepsis and injected these animals with these cord-derived mesenchymal stromal cells. And we were very pleased to see that mesenchymal stromal cells actually improved survival, increased bacterial clearance, so getting rid of the bacteria in the blood, and they may have done so by overexpressing an antimicrobial, antibacteria protein that helps in clearing the bacteria. With the same idea in mind, we thought, okay, why do babies that have BPD also have a poor neurodevelopmental outcome? Is there something specific about bronchopulmonary dysplasia? And here we took advantage of our expertise in stem cell biology to, instead of looking at the lungs, we looked at the brains of our animal model. And sure enough, when we look at particular proteins that are expressed by brain stem cells, SOX2 and nestin, we could see that there was a dramatic decrease in these brain stem cells in the hyperoxia BPD model. And when we then take out these cells and culture them in a petri dish, similar to what Till and McCulloch did with their hematopoietic stem cells to look at self-renewal, we could see that in BPD, these neural progenitor cells had decreased self-renewal, whether it was in the primary or upon replating in secondary neurosphere assays. But when we provide this animal model with mesenchymal stromal cell therapy, we could attenuate this dysfunction of neuroprogenitor cells, suggesting that contrary to glucocorticoids, our mesenchymal stromal cells may be lung, but also brain protective. So the excitement is super high in amongst us neonatologists to see whether these promising laboratory studies hold true in the clinic. So as a summary, I showed you that mesenchymal stromal cells in the laboratory may have promise in preventing injury in those complications of extreme prematurity. But unlike what we thought, these cells do not engraft, stay in the body. Rather, they migrate into the injured area and coordinate the repair process, and then they disappear. And we think that these cells release some products and nanoparticles, so smaller than microparticles, called extracellular vesicles. And when we inject these extracellular vesicles, we get the same beneficial effect on the lung and the brain. And so we call it nanotherapies for micropremies. And we hope that it will hold true in clinical trials. However, we know that the clinical translation often fails and advances at a very slow pace. This is unacceptable. And in our lab, because we are so focused on the clinical translation, and this is the goal number one, our mission is cure lung diseases in babies. There's no shorter way of saying it. And of course, it's a very ambitious goal, but if you don't set a target, you will never reach it. And so because of this knowledge, we took advantage of our method center at the OHRI and created the incubator engine. innovative neonatal cellular therapies for BPD, accelerating translation of research. The logo was done by my daughter, which is the only reason I show this slide. And you can see that it takes a multidisciplinary team, like a health psychologist, an epidemiologist, a journalologist, or a health economist to achieve and launch this incubator concept that is supposed to be an accelerator engine that mitigates the risk of failure of clinical translation. And here I show you how this takes place. And so we inserted this incubator concept between the preclinical and the clinical trials. And you could see it's a circle because knowledge from the bench will be translated into clinical trials, and knowledge from clinical trials will feed back to further improve our therapies at the bench. Here, the incubator contains several components. Here, I will just show you the integrated knowledge translation component where we engage parents early on in our research. And this is critical to optimize and ensure the success of clinical trials. So here, what Mireille Guyot did, the fellow in our unit, she asked the parents specific questions in semi-structured interviews about potential facilitators and obstacles to a stem cell trial. And we did the same with colleagues around the country. And so we enrolled parents that had babies at the gestational ages at risk of developing BPD, and 16 neonatologists across the country, and asked these questions in the semi-structured interviews. And so there were some very obvious responses that we received, but there were also other interesting information that we received through these interviews. But overall, we were excited by the enthusiasm and eagerness to participate in such a trial. And potential targets for intervention were also identified. And so we developed an informational animated video for parents. And I show you here just snippets so you can get a feel for how this could improve enrollment in clinical trials. Let's see.
Cells repair and maintain our bodies because they have the amazing ability to become any type of cell, bone, muscle, liver, or blood. Stem cells are found in certain parts of the body, like the umbilical cords of babies. Umbilical cords are often thrown away after birth, but they can be collected safely after birth without any harm to the mother or the baby. Umbilical cords have lots of certain kind of stem cells called mesenchymal stromal cell, or MSC for short. Our lab was among the first in the world to show that this kind of stem cell can repair undeveloped lungs in lab models and have the potential to help repair injured baby lungs. With that information, we are now ready to try to help treat babies with BPD. Before we start, our team will work with Health Canada to make sure that these cells are safe. Health Canada is a part of the government that regulates research studies on humans, and they have strict rules to make sure that qualified healthcare professionals who run such studies follow cells, repair, and maintain our bodies because they have the amazing ability.
So you can see how this informational video could make parents more at ease to understand what is a phase 1 clinical trials, what are these cells, and how are we going to use them. And so we have tested this information video in our observational clinical trial. And it was very critical to have done these parent engagement projects when we approached Health Canada, because they could see that we did our homework and we went above what any other team has done before to translate discoveries into the clinic. And so we're now ready to initiate HULK-1, which is helping underdeveloped lungs with cells. It's a phase 1 trial to test the safety and feasibility of these cord-derived mesenchymal stromal cells. And here again, it takes a team to get this all done. HULK-1 was split in an observational cohort and a interventional cohort. And the observational cohort was basically a test run for our interventional trial to make sure that our inclusion criteria, exclusion criteria, and endpoints could be collected, and to see how enrollment would happen. And so we learned a lot through this observational cohort that we completed in September 2021. And we received a non-objection letter from Health Canada on December 31st to initiate our interventional cohort. And this trial will be done in Ottawa and also in Sunnybrook in Toronto, because we wanted to make sure that we would be able to finish this trial within 1 year, 1 year's time. And so we hope that this trial will be able to launch and enable a subsequent phase 2 trial in which we can actually test the efficacy of mesenchymal stromal cells in preventing lung injury. However, cell-based therapy is still in its infancy. And a good analogy to explain this is, I think, the development of the cell phone. You can see here the rudimentary cell phone that did one function, making a phone call, was originated in 1983, and it took over 20 years to develop this rudimentary phone into a smartphone that we are now accustomed to. And so this is just technology. Here we're talking about biotechnology, and it may take at least the same amount of years, decades, to harness the full therapeutic potential of the cell therapy. And we may be at this stage currently, at least in neonatology. The cell phone analogy is also pertinent because for cell therapy, manufacturing is a critical component and the process is the product. There are so many steps in the cell manufacturing, from choosing the source of the cells, processing the cells, culturing them, isolating them, storing them, and then freezing them, thawing them, all the way to patient administration. And any step in this process may change the function of the cells, i.e. their therapeutic benefit. And we're still trying to sort out whether we actually should freeze this or should freeze the cells or not, which of course poses some logistic challenges. Should we culture them after we thaw them, or should we inject them right away? And so here, even though we have started now the clinical translation with clinical trials, we're already thinking about the next generation cell therapy using some cool new tool called single-cell RNA sequencing, which allows us to barcode every single cell that we can isolate from the umbilical cord. And then we can follow this cell and look at what kind of genes these cells are expressing, and we can then group them. And the idea is that through this technique, we will be able to fish out the cells that have superior repair potential. This is what we call a UMAP that shows the different clusters of cells based on their gene expression that we get out of one cord. And so here we had cluster 0, for example, cluster 2, cluster 6, and these were very interesting because cluster 6 is actually a control cell. It's a dermal neonatal fibroblast that doesn't have any therapeutic effect. This cluster here turns out to be a mesenchymal stromal cell cluster, but when we inject these into our models, we don't get any therapeutic effect, contrary to this cluster here. And so the question now is, what is different between this one, and this cluster? And also, when we look at the MSCs from term cord versus preterm cord, we can see that the term MSCs cluster together and the preterm MSCs cluster together. And is there a difference between those two? Here again, you can see this is the same cluster of cells that we saw here, and they don't have a therapeutic effect. Again, they cluster separately from preterm to term. And Chanel is currently doing these research in our lab to bring us the next generation of mesenchymal stromal cell therapy. So in summary, I hope that I could convince you that mesenchymal stromal cells have these multiple effects that could possibly improve or protect the lung, but also the brain and other organs in preterm babies. And there's biological plausibility, like a strong rationale for testing these cells now in early phase clinical trials. In parallel, much more needs to be learned about the biology of MSCs along the line of what I just showed you in the last slide. But lessons learned from these early phase clinical trials, well designed, well thought through, will enhance our understanding of cell-based therapies and allow us to get to the next level. It is important that this kind of disruptive technology should always advance through evidence-based knowledge in the lab and the clinic. And we hope that our incubator concept contributes to this more rigorous research, but still advancing at an acceptable speed and to enhance the success of clinical translation. And so in the lab, I would like to thank all the people behind the HALT that made HALT possible in the laboratory. But we all already are working on many other disruptive technologies, like another cell type, for example. We call it the Iron Man project. And here in the Avengers and Fantastic Four projects, we have some very promising gene therapy for incurable genetic lung disease, like surfactant protein deficiency, with Martin as a champion driving this, this project, and Adi working on this new Fantastic Four project to rejuvenate the lungs. Of course, this work requires a lot of funding, and this is where I spend most of my time doing, trying to get the funding. And besides the scientific funding agencies, the biggest in Canada, CHR, to obtain scientific credibility, it is impossible to do this endeavor that I just described with just this type of funding. Philanthropy is critical to go the extra mile and do what we are trying to do. With this, I would like to thank you for your attention, and I'm happy to answer any questions you may have. Thank you.
Dr. Thibault, thank you so much. Wow, there is certainly a lot of hope for the future for our preterm babies, and amazing the work you're doing. I'm going to share here a comment from Mad Al-Jazim. Amazing work, Dr. Thibault and your team. Thank you so much for joining us here today. And you have people joining from Italy and all over Canada. Obviously, there is a lot of appetite for this kind of research and knowledge. And you mentioned where you are now with your clinical trials. But for the parents watching us here today, how does that look like in the ICU? Your baby was just born at 24 weeks. How does that look like?
For the clinical trial, you mean?
Yes.
What are so here the idea is that after 7 days of life, if the 24-weeker is still intubated and requires more than 30% or 30% of oxygen requirements, we get the inkling that, okay, this baby may be at risk of developing moderate to severe BPD, justifying testing this novel therapy. And so we would then approach the parents and ask them if they would be interested in participating in this trial. They would get an informed consent, but they would also benefit, hopefully, from this informational video to educate them about what this trial is all about. And then they can decide if they want to participate in this trial or not. Again, this is a trial to test the safety and the feasibility of MSCs. We will not be testing efficacy of the therapy. This would be in the next step in a phase 2 trial.
So one question that I have for you, for me to understand as a parent, because we talk about a lot of conversation around the umbilical cord these days, right? Like defer the umbilical cord at birth to maximize the baby's potential and outcomes at birth. Are we talk about the same thing, or you're talking about the tissue outside? Because I had asked you that question before, but just to clarify, what part of the umbilical cord are we talking about that the cells are going to be extracted? Does it need to be from the mom, or can be anyone as a bank, stem cells bank? So clarify a little bit that for parents here.
Yes, thank you, Fabiana. So we take the cord tissue. We don't take the cord blood. We take the cord tissue. Out of this tissue, we can obtain billions of mesenchymal stromal cells and can do a full clinical trial with this one cord. And currently, we take the cord of healthy full-term babies that have donated their cord for this purpose. And then with this one cord, we can treat several preterm babies. So it's called allogeneic therapy. And I think that this allows easy logistics, because the cells are ready to use when we need them in a vial. And then when we enroll a baby, we would thaw the cord cells and check for viability. And if the cells are like go through the check and check all the boxes, we would then release the cells for the trial.
Is this an infusion on the baby? How does that gonna look like?
Yes, so it would look like a blood transfusion, except that in transfusing blood cells, we would transfuse mesenchymal stromal cells, these MSCs. And so then we would be monitoring the baby very closely during this infusion process and for the next 3 days to make sure that there are no adverse effects. And of course, we did these studies in animals before, and large animals as well, to make sure that nothing happens. And we didn't have any adverse effects in our preclinical studies. So we don't anticipate to see anything in the clinical trials, but we still have to do the trials to be sure.
Absolutely. So there's a question here in our private chat. Can you please ask him, I'm asking you, if MSCs are found in breast milk? Because you did mention only goes to the injury area, it doesn't spread. So, but have you found, like during those preliminary tests in animals in breast milk?
Yeah, we have not looked at this, and I don't know if mesenchymal stromal cells exist in the breast milk, and how many of them exist in the breast milk. When we're talking about treating with MSCs, we're talking about million cells per kilo, and so we will do a dose escalation study. The lowest being 1 million cells per kilo, the highest 10 million cells per kilo. So if there are MSCs in the breast milk, there aren't that many as the ones that we're infusing in intravenously.
So, okay, I have a question here from Simona. She's joining us from Italy. Thank you so much for joining us. We will look at the effect in the brain.
Yes, absolutely. We will follow these babies typically at 18 months to 2 years in our neonatal follow-up clinic, and we will perform a Bailey's test to quantify neurodevelopment, so that we have actually a quantitative measurement, an objective measurement to assess brain development. And I think that later in the phase 2 trials, the efficacy trials, even though the focus is on the lung, we will see, I think, as an ancillary effect, improved neurodevelopmental outcome. But this is pure speculation on my part, based on what we have seen in the laboratory. But if this happens in the clinic, this would be fantastic.
Absolutely. So one question that I have for you, how long will you follow up on these babies? Because we know a BPD can last a lifetime. We see adults going to special clinics in Europe for BPD. So are you going to follow those babies specifically for lungs?
Yes, absolutely. So what we have scheduled for this phase 1 trial is to establish a registry. And for now, we would call parents every year after the 18 to 2-year follow-up. We would call them every year for 10 years to inquire about respiratory health and general health, to make sure that everything is going well. If we then will design the phase 2 trial, we will have to think about the logistics of following them for like a very long time, because I think this is the right thing to do, especially with this novel therapy. And so we will have to come up with a effective way that is not too burdensome for the families to follow these babies and later adolescents and adults over ideally a lifetime.
Right. So looking at ahead of our time in a lifetime, now you're in phase 1. Let's assume everything goes well as expected, going to phase 2. In your ideal world, in your dream world, how long until this becomes standards of care?
So
parents want to know, because it's not going to change my son's outcome, but this is what we strive for as a community, right? Improving outcomes for future generations. So how, and I love the analogy of your cell phone, but that was quite a few years. So how many years are we talking about here?
Exactly. So I think the message is in the slide, and again, it's pure speculation. You're trying to see analogy, and thank you, Johnny. I see my former head of neonatology in Edmonton, Johnny Van Arde, saying great work, many thanks. It's great to hear from you, Johnny. And so I think the analogy is a pertinent one again. And if you look at technology, pure technology is easier than biotechnology, right? Because we have so many unknowns in the bio part of technology. And so if it takes 20 years to do a cell phone, it will take longer to make a cell therapy. However, along the way, we were able to make phone calls, right? So hopefully along the way, we will be able to cure some BPD, even though we're still fine-tuning the therapy. But it has to go through phase 1, phase 2, phase 3 trials, because this is the only rigorous way of achieving this.
We have a comment here from Simon. Let's hope for an iPhone and not a BlackBerry. Oh, thank you, Simon. Dr. Thibault, thank you so much. I am very excited about this as a parent whose son has BPD and had a lot of brain damage during his ICU stay and has cerebral palsy. I am so excited about this, and I can totally say like a lot of families will be excited about this and hopefully join your study, because this is critical for us to move forward and to have a better outcome for our preterm babies in the future, especially now that the age of viability is dropping. You know, US is going to 21 weeks. We are in 22 weeks in many places in Canada. So I think this is a lot of good news for our community.
Yeah, thank you, Fabiana. And you see like that we give superhero names to our projects. It's to keep our excitement alive, but the real superheroes are the babies and their parents. And I hope that we can give back and make them live healthier lives.
Absolutely, that's what we work for. So here is the website with all information about your research and everything that is happening there, and obviously for grants, because I know there's a lot of money involved in this kind of research. So Dr. Thibault, thank you so much for being with us today. I'm looking forward to hosting you hopefully in the near future, so you can give us some updates on what is happening with their clinical trials. So thank you.
Absolutely. Thank you very much for the invitation, and I'm happy to come back anytime. Thank you.
Absolutely. Thank you. And to all of you watching us today on YouTube, Facebook, or Twitter, thank you so much for joining our live session today. And the video of today's session and all the videos from our live series are available on our website, which is the canadianpremis.org. And I want to thank our sponsor, AstraZeneca, for the ongoing support to our education sessions. And we are a charitable organization, and we believe that through support and education, we can empower families, ensure they are ready to care for their babies. Visit our website, consider making a donation. Together, we can create a brighter future for all our families. And I see you again next Friday, 1 p.m. Eastern Time. Stay well.